So what we're going to take you through in about the next 45 minutes is a presentation around outbreak management and running an incident management team through a COVID lens. So our aims are just to give a brief recap of what COVID-19 is, provide a general introduction to outbreak management and the aspects involved, and then talk about incident management teams in different settings through a particular COVID lens. So remembering COVID as if we could forget it. So just to remind people that so COVID-19 is a member of is a coronavirus based outbreak. Coronavirus is a large family of viruses that cause a wide spectrum of diseases, from the common cold through to SARS and MERS. And the name of the virus is SARS-CoV-2, and the name of the clinical disease causes is COVID-19, so called because it was discovered in 2019. So the disease is spread primarily from person to person. It's also when that infected individuals contaminate the environment by leaving their virus on various implements in the environment, like laptops and doorknobs and lift buttons, etc., so that you could be exposed to the virus via your contact with the objects as well as the individual. And these are the two aspects that you need to think about for all infectious agents, is the incubation period and the infectious period. So the incubation period is when you're first in contact with the causative agent, and then when your signs and symptoms first appear. So ideally, you would like that period to be as short as possible, because then it makes it easier for you to understand where the person might have first been exposed. Then the second aspect that you need to think about with any organism is the infectious period. So this is the time when the person who's got the agent, the infected person, can pass it from person to person. So you might still have an organism, but you might not remain infectious. And that's one of the issues that we're having with COVID, where people remain having a positive antigen test, but their ability to be infectious gets less, but they can remain antigen positive for some weeks. So the symptoms that we see predominantly with COVID were initially fever and dry cough. And as time went on, it was realised that loss of taste, loss of smell were also common enough in COVID infections to be considered part of the symptomatology. The issue with symptoms with COVID, and this is going to become particularly problematic come the autumn months, is that these symptoms are not very specific. As you can see, they are, if you took the word COVID out, you could probably put the word influenza and it wouldn't be very different. And that's the dilemma that we're going to have come the autumn, when differing viruses start circulating. So in some ways, COVID was quite kind to us by appearing at the time of the year that it did. So asymptomatic carriage are those people who were infected, but for whatever reason, they have not got rid of the organism, but it's also not made them unwell. So they carry on with the organism in their body and they can pass it on to others. There's obviously increasing numbers of pieces of work that are being done with COVID, and the crucial aspect that this particular group of people play in the COVID infections. And as time's going on, we're getting more and more information about how much asymptomatic carriage there is. But obviously the proportion of asymptomatic carriers that you find will depend on how closely you look for them. So if you only test people who've got symptoms, you won't find your asymptomatic carriers. So there are different ways in which health services, for example, are organised, which might impact on the proportion of asymptomatic carriers found. So the definitions for COVID are the confirmed cases based on it being confirmed in a laboratory, whereas the possible cases based on having the symptoms from that list that we've just shown. Then the other definitions are around contacts, which we are increasingly defining depending on the level of close contact and the time in which that contact happens in. So the direct close contact is the within 1 meter for 1 minute or longer. But the caveat to all of these is the line at the bottom. So if you are in appropriate wearing personal protective equipment, then even if you are at that level, if you're wearing the appropriate equipment, then you do not need to be followed up as a contact. And that's some of the rules that we are applying in hospitals, where obviously patients have to be managed very closely, and why the PPE is so strictly enforced. So I'll go on now to why do outbreaks happen. So this is the well-known chain of infection, for those of you who've not seen it. So what you're looking at are 3 different things. You've got the host, which is up in this top left-hand corner, which is us for this particular organism. So the host are humans. Obviously, some organisms are host are other animals, cows, whatever. That's one thing. The next thing then is the agent following over, which are these multicoloured, as they always are, bugs of various sorts, bacteria, viruses, parasites, whatever. The third aspect that needs to be considered in the chain of infection is the mode of transmission, which is this bit down in the bottom left-hand corner, which is the way in which the agent and the host interact to enable the agent to get into the host, multiply and cause symptoms, and then can also then use the host to pass the infection on. So the other aspects of the chain of infection that play a role are where the bugs live. So they live in humans or plants or other animals. How they get from wherever they are, their reservoir, into the how they get out of wherever they are, and then the other aspect here is how they get in. So that's the portal of entry. So most bugs get in by the mouth, cuts in the skin, eye, or by you breathing it in. One of the things to notice here is this the host, and there are different things about the host, the human host, that may impact on their likelihood of becoming infected. And there's different aspects of all of these things which will impact on how well or poorly this chain of infection is established and can continue. So you can reduce your chance of an outbreak by 3 main things. You get rid of the agent. So, for example, when we had BSE, we killed lots of cows. You do things to the host to try and either make them more immune or reduce their chances of being exposed to the organism, or you do something to the environment so that the mode of transmission is interrupted, and that's usually around hygiene measures. So the prevention measures that we've got specifically for COVID are listed here. So we have isolation for cases based on the infectious period. We have isolation for contacts based around the incubation period. We have social distancing to try to minimise the chance of, if you are infected, you passing it on to somebody else. Likewise, we minimise large social gatherings and work gatherings, although of course now that has been relaxed and we're allowing more of that interaction to happen. To a large extent, but not quite as much as I thought we were doing, we have prevented immigration and migration, both into and out of the UK, because this is a global pandemic. That particular intervention is obviously less important if you've just got a very localised outbreak, but COVID is global and that's why it's needed. Shielding, where you for those people who are particularly vulnerable, and for COVID it was both age and also your immune resistance, your capability of mounting an immune response, was a kind of extreme form of isolation where people were told to quite severely restrict communication with anybody really. Use of personal protective equipment obviously varies depending on the level of contact you might be having with an infected person or what you might be doing with them. And increasingly, we've now come down to the use of masks for the face coverings for the general population, whereas traditionally for infections, the PPE is more, in healthcare and social care settings, for example. Reinforcing hand hygiene. Hand hygiene is the sort of mantra, I think, of every outbreak management programme, but it's particularly crucial in COVID. And I think we all remember when we thought we were going to be washing our hands every 20 seconds, for 20 seconds, or whatever the mantra was. But it's very crucial, and it is sometimes unfortunate that people think that wearing gloves is better than decent hand hygiene when it's really not, in the general circumstance, obviously. The two things that we've now got more established, which are the more formal programmes around the testing, and increasingly more and more people are being tested for differing reasons, and now the contact tracing programme. So the National Contact Tracing Advisory Service, which has been developed particularly in about the last month, which you've heard about in a previous presentation. I'm going to talk about it only briefly, not in any detail, but just to explain it as a method of preventing transmission in an outbreak situation. So very simply, it's systematically trying to identify people who've come into contact with someone who's got the organism, and telling them about it and asking them to do different things. But obviously, contact tracing also gives you information about how the organism might be spreading, and therefore what you might need to do. Also bear in mind that organisms sneakily change during an outbreak, so they may develop different resistant patterns, or it may be that certain groups become more at risk, and contact tracing needs to adapt in line with the information that it's providing you about when you find the contacts, their outcome from that contact with the case. So you're doing it to identify the individuals at risk and to try and stop onward disease through the three ways that I mentioned here. So the other aspect, of course, is that a contact might at some point become a case themselves. And so it needs to be really clear to the contact that if they get symptoms, they don't just carry on just isolating themselves, but they tell somebody and they do something about it. So that's the brief revision of COVID and outbreaks. I'm going to, why they happen, I'm going on a bit more now into outbreak management in a bit more detail. So confusingly for some people, there's more than one definition of an outbreak. But that's because we've got more than one situation in which the word needs to be used. So the one that we're using have been for COVID is the two or more linked cases of an illness linked in time and place. So obviously you need to have been in the same place at the same time to be able to be linked. The single case of unusual or rare infection, we're really talking about here infections such as diphtheria or smallpox, where to a large extent they really are not occurring in the UK, and so a single case would be considered an outbreak. What increasingly we're having to think about, though, in COVID is this third category, which is the greater than expected rate of infection, because as we're all aware, COVID now has a kind of background level of infection. And this is where there's increasing work being done on exceedance rates, where you're not starting from naught, which was what we obviously when we started with COVID, we weren't expecting, we didn't have any cases of COVID. But now we've got the background level. Just having a number of cases doesn't necessarily mean you've got an outbreak, which means it becomes more complicated defining outbreaks. The fourth category, I think we can ignore for COVID particularly, and is associated with food or water contamination.
So outbreaks are localized. They become epidemics as they become actively spreading beyond the local environment. And usually it's when you're starting to lose control of the ability to manage the outbreak. And pandemic is where it's to do with the geography, and it's where a number of different countries are being affected, and you have a global epidemic. And obviously the World Health Organization has definitions about when they declare pandemics. So outbreaks occur for a number of reasons, and they sometimes occur when more than one of these instances happen. So you can have an outbreak because something has happened to the agent. There's more of it around, or it's acquired a degree of resistance. So whereas before you could prevent it by using an antibiotic, it now no longer can be used that way. So something like gonorrhea, where the resistance profile of the bacteria changed. Or you can have an outbreak because the agent was introduced into a new setting. So this may be where there's been no exposure to this agent before, so there's no underlying immunity. So COVID is an example of that, because we had very little background immunity to COVID, so everybody was more or less susceptible at the beginning. Something can happen to enhance its mode of transmission. So there may be something in the environment that enables the organism to transfer from people to people more. There may be something about the host that has changed. So the host may become more susceptible, either maybe because it's the person's immune system is affected in some way. So that's why sometimes we have outbreaks in hospital, because they happen on wards where individuals have poor immunity. Or there's an increase in the exposure of the host to the organism, either because, for example, they may be overcrowding, as an example, or something happens so that there's a new way in which the agent can get into the host. So I'll leave you to reflect on how you think these 6 different aspects might have the influence they might have had through the COVID lens of the reason why we had the global pandemic. We might not know the answers to some of that. It might involve bats or wet markets that we're not sure. So if you want to try and establish the problem, that's trying to decide if you've got an outbreak. Every outbreak starts with a case. So you need to have a really good case definition. And obviously with COVID, we have our case definition. But as I've mentioned before, it is a problematic case definition because it's not very specific. So you move from having a single case to having clusters. So that's where you've got more than one case, and at that point you don't know how they are connected. When you find the connection between clusters of cases, that's when you then have an outbreak, because they'll be connected in time and place, as mentioned before. But there are some instances where an outbreak is not an outbreak. So those are listed below. So it may be that you have got better at just finding it. So the actual circulation of the organism is no different. It's just you found out where it is. You might have done something to enable the data to be better collected. You may have also done something, and that's the size of the at-risk population might have changed, or the laboratory test may be false positive, so that maybe the test has told you that you've got COVID or whatever organism it is, when in fact you haven't got it. So if you're doing an outbreak investigation, these are the steps that you need to go through, and it is important that you kind of go through it methodically in the order. So obviously, first of all, you have to work out whether you've got an outbreak, and you have to rely on people to tell you that they think they might have an outbreak. Then when they've told you that there may be an outbreak, in whatever way you may be finding out about, you need to confirm the diagnosis of the cases associated with the suspected outbreak. And that's where you have the role of the case definition and the case finding, as we've mentioned. So those are the measures that you do to actually find out whether you've got an outbreak. You then want to put in place immediate control measures based on what you know about the organism and the people at risk and where you think why you think the outbreak happened. And you use data to inform the aspects around the outbreak as to why it might have happened, whether your control measures are working, whether you need to change your control measures, etc. It's really crucial that these two things at the end happen. And often in outbreaks, I think it's fair to say they are the poor neighbours. So the communication of findings is really important to enable others to learn. And also the debrief is important because that's the way in which you sit round a table politely, work out what worked, and work out, more importantly, what you would do differently to try and minimise the chance of it happening again. So the last part is talking about the incident management team, which in my days, because I'm so old, it used to be called the outbreak control team, but they're more or less the same thing. So the IMT is there to try and bring together the different elements that are needed to manage an outbreak successfully. It's there to provide the focus for the work, to agree the work programme, to understand why something is going on, and to understand the impact of the measures that you've put in place, and to enable the coordination of all those measures in the most effective and efficient way. What the IMT is also crucial in understanding is whether the control measures are working or whether you need to escalate it to either include other people or actually more widely nationally. And the very important role of the IMT is actually to decide when the outbreak is over, which should be done in the IMT, not out with, the IMT. Now, you have an IMT to investigate an outbreak, but there may be different aspects of that outbreak that are particularly specific to your incident. So it might be that you think you've put control measures in place, but still the numbers are going up. You might be that you aren't quite sure if you've got the control measures in place anyway. It may be that you're needing to use your IMT because you're really unclear whether it's a cluster, an outbreak, or increasingly whether, for example, in a hospital, you might have more than one outbreak on a number of different wards, or in a community setting where you may have an outbreak in a school or a social setting, and whether they are the same outbreak in different settings or one. It may also be that you've got inconsistent information from several sources telling you different things about whether you have or you haven't got an outbreak. And it's crucial that that is sorted out through the IMT. We often hold an IMT when there is the first outbreak in that particular setting. We are sometimes asked whether you have to have an IMT in all outbreaks, and there's not an exact answer. Increasingly with COVID, where the situations are often novel, you need an IMT because it may be the first time that setting is being investigated. But for example, with the hospital outbreaks, after we'd had quite a few of them, it wasn't necessarily the case that an IMT was declared for every new outbreak, but the methods of working have been well established through previous outbreaks and IMTs. You may have to hold an IMT because there's lots of media interest for whatever reason, and some of which might be relevant and pertinent and some might not. The timing of the IMT is the other tricky one, because you need to hold it early enough so that you actually manage the situation. But one of the most disappointing IMTs is where the answer to every question is we need more information, because that really doesn't mean that the IMT can do its job properly. But going back to the previous slide, we really need to think about the questions that your IMT is trying to answer and assess whether delaying an IMT, for example, by 24 hours will mean that you will have more information and you will be able to hold a more constructive IMT. The other thing to think about when you're holding your first IMT is that it might be the first and only, and you may not need another IMT, or it may be one of a series, either because of the extent of the outbreak or the amount of coordination that the response will be needed. But there's no exact science to this, and you'll need to work it out through the IMTs as you hold them. This rather complicated table is a risk assessment process. This is not COVID specific and is general to you working out within your IMT the risk assessment of the outbreak based on the severity of the condition, the uncertainty of your hypotheses about how it happened, the way in which the spread might or might not happen and continue to happen, how easy or hard it is to put in the interventions to bring about the effect you need, and also the background context, so whether people are clear about what they need to do, or whether there's press interest, etc. So this is a very generic agenda which can be used in most IMTs. So you're obviously doing the initial niceties, and then you need to clearly set the purpose of the meeting and the background, so that as much as possible all members of the IMT are and have the same knowledge to be able to inform debate appropriately. You need to look at all the data that you've got available, and you also need to be clear the data that may be not available at the time but is being worked on and should be available for the next meetings. The really crucial bit of the IMT is to understand why the outbreak happened, because why it happened should therefore be informing the risks that exist and the risks that need to be managed, the risks that have already been managed and the ones that remain. And those will be through your control measures, some of which will be quite simple and might already be in place, and some which might be more complicated and need a discussion within the IMT, maybe because of the resources that are needed to enable them to happen. It may be that your first IMT it's very straightforward. You've got relatively few cases. The way in which the outbreak happened is clear. The way it can be managed is quite clear as well. But more likely, it will mean that you need to do, especially in the case of COVID, there'll be a degree of contact tracing that will be needed and more testing that might be needed. It may be you need to be clear about the cases. So, for example, if people are reporting that they had a positive result but they were asymptomatic, to make sure that that was actually the case. Sometimes on closer examination, it's not the case. It's really clear that you agree the actions, but also who's going to do the actions, and sometimes it may be a timescale is needed. The communication strategy is really important, outwardly facing to the media, but also to those people that are affected by the outbreak, the cases, so that they are aware of what's happening, and obviously any other business, and then the next meeting. So for the final part, we're just going to talk a little bit about outbreaks and COVID. So the first scenario we're going to look at is a care home. Now, it's good that the number of outbreaks that we're having in care homes are now going down quite considerably from the high levels that we had earlier on in the year. But these are the kind of questions that you need to think about where you're in a care home, where obviously you've got a close interaction between staff and residents. And often you've got residents who is quite difficult to find out maybe when they first become unwell. They may have lots of comorbidities, and understanding exactly when they might have first been exposed to COVID can be quite difficult. It's obviously the other issue in care homes, which is sometimes that people have got dementia, and their ability to provide the information and comply with isolation measures might be quite complicated. It's really clear and crucial that the care home needs to have a good infection prevention programme. And as time goes on, it is a concern that there will be IPC fatigue in care homes where they feel like they've been dealing with COVID for so long, and the potential for forgetting what the IPC they should be using will start to be introduced. Social distancing in all work settings is an ongoing issue, and it can never be underestimated as to how much that needs to be reinforced in these settings. It's clear that staff are often very good in the immediate contact setting, but then as soon as they leave the resident or the patient, then all that memory seems to be lost, and they think they can stand next to the individual that they've just thought they couldn't. One of the particular aspects that for care homes was found out about was what's called on here doff and donning. So although care homes were aware about cleaning surfaces, etc., what they hadn't really been told about was how to put on and take off PPE, because to a large extent they hadn't had to use some of the PPE they were using, or they hadn't had to use it as much as often. So that's one of the particular aspects that the training that was organised through the directors of nursing in the CCGs that was offered to all care homes in the Midlands particularly concentrated on. So if you're holding an IMT in a care home, these are the kind of people that it's likely that you would need to be involved in. The chair for an IMT in a care home is usually the consultant in community disease control. It's really crucial, obviously, that the care home provider is part of the IMT. That might be a combination of both the local person who runs the home, but if it's part of a chain of homes, it may be that there'll be some corporate person involved as well. One of the issues, obviously, that could come up in a care home is if you find that the ability of the care home to provide care for those residents that are both affected and unaffected is severely compromised because of the effect on staff. And that's a particular role that the Director of Adult Social Services would need to be playing a role in. They may not be in the IMT that actually when it's held, but they may be a crucial contact point if the outcome from the IMT is that it's actually not, that the home can no longer provide the care that residents need. The graph that you've got on the right-hand side is actually data from the Midlands care homes. There is a Midlands care home cell that meets every week. It met at lunchtime today, and this is the data that PHE provides for it. So as you can see, we had a week 14, which seems like a long time ago now. We had loads of outbreaks all over the place, and now we're down to very small numbers. That's across the Midlands, so that the impact in care homes is much less, although it's obviously not disappeared, and we need to remain vigilant. So school outbreaks have more recently started to appear, and there's different concerns obviously in a school where you would hope that the children, you're not worried about children's immunity as you would have been in the care home, but there are various issues that the school outbreak itself raises, not explicit to schools, but specific, but maybe more of an issue. You need to be really clear around the issues around ongoing spread, the case definition, particularly when we had children who were being were shielding and were maybe being withdrawn by their parents because they didn't want them to be in school. That is less of an issue now, but was to begin with. The control measures in school, obviously this is a school, not a hospital, so making sure that they've got the right precautions in place, understanding how the school is laid out, the social distancing aspects, etc. The media like schools, they like stories that involve children, so you may find that the media spotlight is particularly shining on your school outbreak. There is the increasing issue as well, whether the school reflects the community it sits in, and whether the cases that you're finding in the school are due to spread within the school or whether they just reflect the spread in the local community. And that's really quite difficult to understand, but needs really careful scrutiny, because the worst thing would be to assume that it's not a school-related outbreak when in fact it is. These are the areas where you might find that you've got either increased concerns about the way you can manage the outbreak or the spotlight that's shone on you. A death in a school is obviously tragic, but also the media interest in such matters is huge. It may be that you've particularly got a concern because of the sort of school it is. If it's a school that has a higher portion of children with special needs, for example, they may actually find it very difficult to comply both with any testing regime or the social distancing that you may have in place. Obviously, if you've got lots of cases, if the outbreak's still going on, even though you think you've got the control measures, the school is finding it difficult to run because of maybe the staffing or other factors that might make your concerns particularly raised in a school. So the IMT in a school, obviously a slightly different combination, but you need representation from the school itself, the local authority, children and young people's rep. Depends entirely on the way in which your local authority has decided that schools kind of need to be covered from this point of view, and the local health services, it might need to be involved depending on the arrangements with the children. And what I've put here on the right hand side is actually a petition that was started way before we had closed schools, where there was a national, I don't know if you remember this, there was a national campaign to get schools to close, and how soon we forget. And now we're trying to get them all reopen again, so times change. Coming on to the next scenario then is the hospital. We have also fewer and fewer hospital outbreaks. The hospitals are also becoming slightly complicated because we now have red and green pathways for patients, increasingly as the hospitals try to reintroduce services. So the green pathway is for those patients who are thought not to have COVID, and the red pathway is. Obviously, some interventions cannot be delayed, although there is increasing concern that patients are refusing to come into hospital because they are so concerned they'll get COVID. But if you have a COVID positive patient in a COVID ward, that brings up different issues to a COVID positive patient who's in a non-COVID ward. It's obviously increasing interest as well around the nosocomial aspect of COVID, so whether the patient acquired the COVID in hospital or whether they brought it in with them. Aerosol generating procedures are a particular things that you do, like a bronchoscopy to somebody, that increases the chances of the virus being spread. And that's a particular area that you would want to be looking at. Increasingly, the healthcare worker aspect is becoming complicated as the test and trace processes become more and more developed, and more healthcare workers are being tested. But it's crucial that any possible healthcare provider has a really clear understanding of what it does with the results that come from the test and trace for both its patients, but also for its staff. So all hospitals have to report their outbreaks to Public Health England, but they also have to report them into NHS England using what's called an II March form, and that is got some aspects around business continuity. So obviously for NHS England, their concern is that if you have an outbreak on a ward that has to then close, the impact that has on the health service, maybe within the hospital, but maybe more widely if it's, for example, a neonatal intensive care unit. All hospitals also have to send in a daily update on the new cases for both staff and patients. And more recently, the root cause analysis has been introduced so that now any new nosocomial infections have to have a root cause analysis filled in So that's a more detailed investigation as to where they may have got the infection from. But we have got fewer and fewer cases of COVID in hospital, whether it be people who've brought COVID in with them or acquired it whilst they were in hospital. And the numbers, as you can see from the top graph there, has changed considerably again from the beginning of April, when everything was kind of kicking off, to where we are now. This bottom slightly blurry slide picture rather is from a document that was sent out from NHS England to all hospitals about what they needed to do for an outbreak. It's still the case, so that there is supposed to be a hospital SOP, standard operating procedure, SOP, which is still being written, and unfortunately so far hasn't seen the light of day, but we all hope it will soon. So the IMT in a hospital is more likely to be chaired either by the Director of Infection Prevention Control, that might be an executive nurse, or that person may also be the consultant microbiologist. It depends from trust to trust how that is organised. So they would usually be chairing it with various different people involved. I think that's all kind of self-explanatory. The commissioner here, obviously some hospitals, the main commissioner for all hospitals would be the CCG, but it may be a case that NHS England might be involved, either because of the sort of services that are happening. There is an infection prevention resource within NHS England that will attend some trusts if they're outbreaks, if they're thought to be particularly problematic, but they don't go to all IMTs. So the last aspect is the community outbreak. This is obviously very much in the news, and is need to think about the community outbreak when you've maybe got lots of outbreaks, and trying to identify the source is getting complicated. Where just bringing everything together means that you have economies of scale, you can collate data, and obviously crucially a community is made up of people, and the community needs to be part of the debate, not just the recipient of the action, because without that some of the control measures you might have put in place will be less successful than they might have been. But it is very complicated to manage community outbreaks, and cannot be underestimated the amount of both attention that they will gather. And as we're all aware, Leicester at the moment is bearing the brunt of the media scrutiny. IMTs in the community, I think this was probably one of the hardest slides I had to try to pull together, really, because it very much depends on so many different things as to who you might want to be involved in this outbreak. The Director of Public Health with their environmental health colleagues, and probably other colleagues from the local authority, would be usually in the chair in a community-based outbreak. Or it could be the PHE consultant in health protection. Really depends on the context a little, but there's a whole host of people who might be involved. I think this slide could have probably gone on to about 2 or 3 other slides as to who altogether might want to be involved, depending on where your outbreaks were happening. And the slide on the right is the various levels, if we all remember the Boris slide about what level we're at and what should be happening. And hopefully we're going to carry on going down, not go back up again. Okay, that's it for the slides. I'll end the slideshow there and come back to the meeting. So, Carol, how have we been getting on?
Thank you, Annette. Well, I've tried to pick up all the questions in the chat. Can you hear me okay? Because I can hear myself coming back.
Yep, I can hear you.
Yeah, fabulous. So we've had a few interesting questions. One was around asymptomatic individuals that test positive. Of course, this may be because they're being screened as part of their key worker role, but we're also aware that contacts of confirmed cases, despite being asymptomatic, are sometimes being tested. And it was about how we contact trace those and how infectious we consider them to be. So for those, we actually contact trace for 2 days before their date of test. up until 7 days afterwards if they've still been having contact with people. And we consider them to be less infectious than someone who has symptoms, but they do still warrant contact tracing, and of course they must isolate themselves too. The next question was around pharmacies and the guidance for PPE. Karen raised a really important question there. I think for us, actually, we would say that if you are having close contact and you aren't able to maintain social distance, you should be wearing PPE. And then we had some questions around when will people be able to visit care homes, both for older adults and also younger adults. And my response was that we are still at alert level 3. We still have sustained community transmission, and I'm sure this is kept under review nationally, but of course at some point we may move to regional variation in practice. But for now it's not possible, I suppose. And then the next question, we think, but Dawn might want to come back to me, we think it was around whether I think it was sort of about how we identify contacts and whether the use of PPE is sufficient to prevent someone being identified as a contact. And certainly we're very clear in a healthcare setting and a care home that if you have been wearing appropriate PPE and had close contact, we wouldn't recommend isolation. But for those that are not healthcare workers or care staff, we wouldn't necessarily use the use of PPE to determine whether they had to isolate or not. We would actually gather information on the type of PPE used, whether they were trained to use it, the length of contact, and would be much more cautious about allowing them to remain in the setting. And then I think there's just been a couple more questions. So Simon put, I've recently dealt with a pub who had a customer visit them on Saturday and then tested positive without symptoms on Sunday. The pub did not hear anything from Test and Trace, but decided to close and get their staff tested. In this circumstance, how do they check the customer who was believed to be the case was in fact the case? Yeah, good question. So ideally, what should happen is that when the person is a confirmed case, they obviously provide their details to the NHS Test and Trace system, either through the online web-based tool or to a call handler. They should disclose that information, and then it's still being debated actually whether that's followed up in tier 2 call handlers or escalated to ourselves in tier 1 that pub. But certainly we would want to identify if there had been any close contact in the pub setting. How should they, I mean, I presume the pub's always welcome to contact us and we can give advice. I don't know if they would know the name of the customer. And I suppose the other tricky thing is that often social media has got involved, hasn't it, before us?
Yeah.
And then there's
I suppose, Carol, the other thing, sorry, I just wanted to add to the other thing to I guess remind people is that the test and trace can only work on the information that the individual has shared with them. So we're aware of instances where individuals maybe haven't been as complete in that information sharing, and so it's not that people didn't do something, is that they weren't aware that the action was needed from the conversation or the information given. So I suppose it's always to bear that in mind, that people just don't know what they don't know.
Okay, excellent, good point. And then Lindsay asked, what about outbreaks related to a large warehouse? I don't know specifically what to mean, Lindsay, but we certainly have been following up several outbreaks in large warehouses, workplaces. They're notified to us either through the test and trace system or through reports to local authorities or from the business directly to us, and we'll always gather information on the cases. We'll confirm that they're confirmed cases. We'll verify the information. We'll review all of the measures they've got in place. Are they able to social distancing? Have they got staggered start times? Are they social distancing in the canteen? Are they social distancing at the smoking shelter? We'll have a very thorough information gathering process and risk assessment and give advice around that. where if it's a large warehouse with several places, we'll obviously often arrange an IMT, as Annette went through. I don't know if that answers, but come back to me if not. Then Chris has got a question. What is the approach or process in the West Midlands for dealing with people willingly not following isolation guidance either if cases or contacts? Yeah. So interestingly, there was actually guidance yesterday. We obviously have legislation and we have powers, and there's been guidance yesterday. I haven't had a chance to read it. I wish we weren't recording that, but never mind. That I think does outline a very clear process for that exactly. So I can share that with you, Chris, after this. Then the next one from Sally. Will staff who provide intimate care for students need to wear full PPE now, previously only wearing gloves and aprons? I don't quite know what setting that's relating to, but I would have thought anyone providing intimate care would need full PPE. Yes. Yeah, because we are in sustained community transmission currently, so we're in the PPE guidance. We're on that table 4, which would recommend better PPE than that. Oh, Mary, who should be checking health risk assessments? No, good question. I'd have deferred to the local authority on that one, but perhaps someone else could answer for me. Deadly silence.
Yeah. Okay.
So does anybody want to ask any other questions or share any experiences or challenges they've had, perhaps?
It should be local authorities that check pubs' risk assessments. They're the enforcing authority if there's a problem.
Yeah, thanks, Nikki.
Okay. I was just if people haven't got any more questions and looking at the time, you know where we are. You've got the slides from today. If there's any queries that occur to you after this, then please get in touch. Please share the slides with whoever you want to. There's nothing on there that's controlled or anything. Hope you all find it helpful, and thank you for joining us.
Thank you.